Welcome to Psychology of Us, where we explore the deeper connections between the mind, the body, and the experiences that shape our lives. Today we turn our attention to something that quietly influences nearly every aspect of a woman's life: her hormones. Hormones shape far more than physical health. They influence how we feel, how we think, how we sleep, how our bodies regulate energy, and even how we experience ourselves at different stages of life. For many women, the hormonal changes that occur across the lifespan, from early adulthood through midlife and beyond, can feel confusing, unexpected, and sometimes misunderstood. And yet, for many years, women's hormonal health has received surprisingly limited attention in research and public conversation. As a result, many women have had to navigate changes in their bodies and well-being without clear explanations or support. But science is beginning to catch up. And today, endocrinology and metabolic medicine are revealing just how hormones influence metabolism, weight regulation, mood, and long-term health. In this episode, we explore the hidden world of women's hormones and the ways hormonal changes intersect with both physical and psychological well-being. Joining us today is Associate Professor Niloufar Tokamani, a Melbourne-based endocrinologist, physician, and academic. She serves as a head of medical weight management services at Austin Health, and she's a strategic development and service innovation lead in endocrinology. She is an associate professor of the University of Melbourne's Department of Medicine. Through her clinical work and research, she focuses on metabolic health, obesity, diabetes, and women's health, helping patients better understand the complex relationship between hormones, metabolism, and well-being. Through both her clinical work and research, Dr. Tokamani has become a trusted voice for women navigating health changes, from menopause and weight changes to diabetes and hormonal disorders. Today on Psychology of Us, let's explore the powerful connection between hormones, health, and the psychological experience of living in our bodies. Dr. Tokamani, welcome to Psychology of Us.
Thank you.
It's such a privilege to have you here. And we'd like to start the conversation about such a global topic as endocrinology, which connects many systems of the body: metabolism, reproduction, and overall health. And I'd like to ask you, what fascinates you most about hormones, and what do they actually do?
Thank you so much, Veronica, for having me. This is very exciting to be here. That's a great question, actually. So the fascinating thing about hormones is there's basically no function in our body that is not regulated by hormones. And that's extreme and big and very hard to actually define in a sort of a small pieces. What happens, what goes up, what goes down. Our body is very smart. We've got a negative feedback mechanism in the body, that the body senses things. If there's too much of a thing, it reduces it, and if it's not enough, it increases things. So that was what I really liked about hormones, maybe the mathematics behind it and the logic behind hormones.
So your impressive work, and I just really went through your profile, and you're doing practical work and research and so many things. You're advocating for the overall women's health. And what are some of the most common concerns women bring to you?
It's a very wide range. So the most important thing that women come to me is, I don't feel myself, but no one can pinpoint anything on my blood tests. And that's a big thing because, as I said, this is such a complex area that not one set of bloods or investigations can tell us what's happening. And unfortunately, there's a big gap in women's health research as well. So the evidence is out there, or the guidelines that we have hasn't caught up. So we are relying on clinician experience for a lot of our decision making.
Oh, wow. So you said that there is a gap between in the research. And what's the gap about? Is it between women and men, or is it between the just looking at the problem of the hormones?
Sure.
Could you tell me about that?
So until very recently, women were excluded from clinical trials in general. So there was no women, and women were looked at as a smaller version of men. So that's one big gap. And the other thing is, out of all the research internationally, only 5% of the research is directed towards women's health. And out of that 5%, 4% is reproductive health, and only 1% is non-reproductive.
That's incredible. That's really mind-blowing statistics in not a positive way.
It is. You know, the general concept of focusing on women has been, okay, we focus on you getting pregnant, and if you don't want to get pregnant, we focus on you not getting pregnant, so contraception, and that's it. So that is what has been looked at. But then we don't have research looking at changes that happen through different phases of life, perimenopause, premenopause, and menopause and after. So it's a very, very evolving sort of a hormonal state for women going from their 20s to their 50s.
So women even don't know what to expect in certain stages of life, and they just go as it comes and really lost what to do with that.
Exactly. Okay. The female body is amazing. It is very amazing. The changes, so from a natural point of view, from a physiology point of view, yes, our body is focused on continuing the race of humans, and that is by getting women pregnant. So all the changes that happen from puberty onwards are focusing on making sure ovulation is happening, making sure that there's a good environment for a baby to be made, and afterwards it's all towards, okay, the eggs are running out and we go through menopause. But that is not the only factor for us. So the woman's body, the hormonal changes are extremely different, and on a daily basis they can change. I can tell you, and this is a very sad thing, that in medical school there is only one subject at one semester about 2 or 3 credits about female health as female hormones, and that's it, done.
So how did you come up with your training? Because your training is quite extensive.
Yes.
And you said that there are only 3-4 people trained like yourself at that level?
So women's health is underserviced area, even in Melbourne. As an endocrinologist, when you are training to become an endocrinologist, there's only one hospital in Melbourne that actually provides a dedicated women's health service. So if you don't rotate through that hospital, you don't get any teaching. And as a result, when you don't get any teaching, it will become a too hard basket sort of scenario and an unknown field. So you need someone to mentor you and teach you. I always had a passion for women's health, especially with the sort of gap that I see in multiple aspects in women going through life. So I self-taught myself, studied, went to conferences, international conferences, and through experience. And we're trying to upskill our next generation endocrinologists. But unfortunately, I have to say that it's been a few years that I've been trying to get funding to establish a dedicated women's health clinic in the hospital that I work, but we can't. And it's not a priority at the moment.
Priority, okay.
But we do have a men's health clinic.
And we do have men's health clinic.
Yes.
Oh, that's definitely a gap in the research and practical approach. I know it's too early in conversation, but what would you think, the future of endocrinology if we are this is the current state of it?
Yeah, no, I think the future is bright because we are changing. There is changes, like there's even policy changes happening. So I'm very happy to say, like, at least in the, even in the governmental stage, we had funding for Medicare subsidized hormone treatments that were not available, and all treatments were only subsidized. So, our voice is being heard. There has been changes and there has been steps. But I think, women are 50% of the population, and one can argue that even more important than 50%, because the structure and the dynamics of a family are dependent on the females of the family. It's better than what it was, but there's a lot to do still.
Oh, it's good to hear there is some progress.
Yeah, there is some happening. Yeah.
And you mentioned that about hormones, or I've heard a lot about, and I know the audience also heard about hormone replacement therapy. There's so much confusion around it. Is there pros and cons? And some people just really try to avoid it at all costs because of different, stigma around it. What's your professional opinion?
Sure. So I would like to split that into 2 phases. One, hormone replacement therapy for women who are going through menopause and perimenopause at the age that they should be going. Let's going through that. Let's say 45 years onwards. Then we look at women who are going through these changes at a younger age that was supposed to be. So let's say in their 30s, or going through early menopause, or menopause because of any other issues like surgical menopause and these kind of things. The second group, which are younger women, they certainly need replacement, regardless of what the cause was, unless there's certain contraindications. It is like putting a 30-year-old body into a 70-year-old body if we don't support these women. And this is really important because in the past, women would go through surgical management of different diseases, let's say endometriosis. Endometriosis, some people call it, refer to it as like a sort of a cancer because it's endometrial tissue outside the uterus, and it can be extremely painful, extremely problematic, causing a lot of adhesions. So sometimes these women need to go through surgical management to take the endometriosis out, and if it's very severe, they would need to take the ovaries out as well. And if that happens, let's say at the age of 30, someone goes through that, and we don't give them appropriate hormone replacement therapy, that will mean that person would be exposed to accelerated aging, osteoporosis, heart disease, cognitive issues. It's technically unethical not to offer these people. And yes, we have different types of hormone replacement therapy. We are very, very fortunate to now have bioidentical hormones, which are exactly like our own body hormones. So they're not synthetic, and the concerns that we had previously with the synthetic hormones do not exist with the bioidentical hormones. That brings me to the second group, the group that are going through menopause and perimenopause, which are normal phases of life. But then looking at the person, we have to make individualized decisions. You know, someone is going through menopause and they are sweating all night, they can't sleep, they are emotional, they are in accelerated bone loss and losing their bone. You know, when we go through perimenopause, in the first 3 years that our estrogen level drops, do you know that our bone loss can get up to 5 times faster than what it was?
That's incredible. What about, is there anything, or can we use that replacement therapy just a little bit before that to catch those symptoms, or we have to wait until we see the actual pattern of that, or we can prevent it?
So
just a step
the osteoporosis, you mean?
Osteoporosis, or generally the whole symptoms of,
I tell women, be very vigilant about your symptoms. We do not replace anything prior to people going into perimenopause, but perimenopause can happen up to 10 years prior to menopause. So it can start at the age of 40 or 39. So there's no such thing as too young to go through perimenopause. And while our blood tests are not 100% diagnostic, they are very helpful in ruling in perimenopause, not ruling out. Because the hormones in a female body go up and down on a daily basis, doing a pinpoint blood test might not help us, but it might also help us. I might be lucky and I might do the blood test at a stage that the person is in a very high estrogen level or has dropped down to a very low. So that gives me the diagnosis or the clinical symptoms, which are the main symptoms: irregular menstrual periods, poor sleep, dry skin, hair loss, mood changes, body aches and pains. I have women who come with vertigo, dizziness, and it's because of menopause, because we essentially have estrogen receptors everywhere.
Amazing, but I'm sure many women would not, associate that or connect with some symptoms. They will be just saying, "Oh, I just feel not well on the day."
If someone is feeling different, having a series of symptoms that they can't make sense of, always trust your body and listen to your body and reach out for help. Don't think that I'm too tired, I've got small kids, I've got aging parents, it's all because of that. Trust your body. You've had all of that for a while. So if there's been a change, it's really good to reach out to a doctor or a specialist who specializes in the field.
Seems like there is not many choices to make.
Exactly, that's the problem. That's the problem that we have at the moment. But there are certain organizations in Melbourne. There are a very good group of general practitioners who are upskilled and trained in women's health, and there are a group of endocrinologists as well. There are an increasing number of doctors. So finding the right doctor, talking to them, having a list. I always encourage women to, when they go to their doctor, have a list of your symptoms, because one of the main symptoms of perimenopause is brain fog.
Okay.
And so you'll forget.
You might forget everything at the time of the appointment. Okay.
Yeah.
I just want to ask as well, some women, when they start searching for the right doctor, I've heard the feedback that they feel very emotional when they start sharing their symptoms, but they're not taken seriously. They actually are told that that's just the phase. We don't know, your blood test is okay. Yes. And I was wondering, just how do they go about it? Do they just keep searching?
There's a list of doctors on the Australian Menopause Society website. Okay. It's not limited to that list, but these are people who have an interest in women's health and have been, you know, trained more than the general sort of population of doctors that you might see. So that's a good place to start. Or asking your GP. So some GPs do not specialize in women's health, but they would know who to refer to. But I would really want to clarify this. Having a normal blood test doesn't rule anything out. And we have to look at the whole picture. And always, sometimes you think the blood test is normal because it's within the reference ranges that the lab reports. But those reference ranges don't mean anything if you don't put it in the context. What time of the month was that blood test done? What phase was it? And all of these things are very important.
Well, it's very complex. That's how it sounds to me.
Yeah, it is complex. Yeah.
Okay, and then I just want to also get back to what you shared about, for example, a woman had some removal of the ovaries or the uterus altogether. And the angle of our conversation is how the hormonal changes affect identity of a woman, her psychological well-being, and how does she feel about it, and the connection between hormones and psychological well-being. What's your perspective on that?
There's a very big connection and multiple layers of it. So there's very clear research that women have estrogen receptors in their brain, and different women have different levels of it. In my experience, and based on the studies that we have seen, the more high functioning the woman is, the more estrogen receptors they've got on their brain. So women have multitasking sort of abilities. One of the major things that women come to me with is, I'm getting brain fog, I can't multitask anymore, I'm not keeping up with the level of function that I used to have, and then anxiety kicks in. So because of the roller coaster of the hormones that happen on a daily basis in a month in perimenopause, just imagine one day the hormones are extremely exceeding what they should be, so there's high estrogen levels, and then in a matter of hours or a day, the hormones can drop significantly down. There was one study that suggested that if a man goes through the same hormonal changes that a woman goes through in perimenopause, they'll be hospitalized. That's how volatile the hormones are. So women come in with extreme anxiety, mood changes, so even aggressive behavior, change in their personality. This is not them anymore. And a lot of marriages break down, a lot of relationships break down, and the standard treatment for many years has been antidepressants.
Oh yeah, I was about to elaborate on that, instead of searching for endocrinologist or any other symptoms, the people start going to and get antidepressants or even going for the talk therapy, but in fact it might feel even worse. So what can we do as a next step? Let's say we are aware that we have hormonal changes and we start going for the checkups. Is there anything we can do to kind of regulate our whole system without medication?
Yes, there's a few things that we can do. Hormones, female hormones, estrogen, so sex hormones, if we call them, estrogen, progesterone, and women also do have testosterone, which is the main hormone. They are fat-soluble hormones. So the less excessive body fat mass we would have, the more hormone availability we'll have. So even if our ovary is running out of hormones, if we have a good metabolic health, we'll have more availability of the hormones and more balance. So what I really tell women is, after the age of 40 or around that timeline, focus on your well-being, focus on a clean diet, reducing carbohydrate intake, minimizing alcohol and caffeine as much as possible, putting in weight-bearing exercises and exercises in your daily and weekly routines, and also practicing mindfulness and techniques that would really help as a sort of a holistic approach to it. So the cleaner the life is, the less stresses that we have.
Can medication help you only if you don't do anything else? If you have bad sleep, bad diet, no exercise, can medication alone help regulate
It can.
hormones? It can.
It can, but it won't have its maximum effect. So I have people who have extreme horrible sleep, and then that is mostly because of progesterone deficiency. And when they start the hormone replacement therapy, the sleep gets better. It's become deeper, and they don't have that 2 to 4 a.m. early morning awakening anymore, you know. But yes, it has a limitation. So the more people do it as a holistic approach, they will get better results of the same hormone levels. But the better you control everything, the hormones will work better.
It's just really good to know, like, the variety of options, you know, and then put together everything you can in order to help your own well-being.
Sure.
And probably another burning question from our audience: do you have to be forever on hormonal replacement therapy or not?
No, there's no sort of obligation. I usually tell women I would suggest for the first 5 years of going through changes, at least to cover. And if I want to go by an age, usually that's an average age of 55 to go through. Why? Because we want to protect the bones. We want to have as maximum effects that we can have on brain function, cardiovascular function, and cognition. The vasomotor symptoms like hot flushes and sweating and all of that also improve after the first initial sort of changes that happen. After that 5 years, the bone loss slows down, the weight regain slows down, and the collagen loss in skin and hair also slows down. So a lot of women are able to slowly come off medication. Again, there's no obligation to take. The previous recommendations that women have to come off hormone replacement therapy after the age of 60, or there is increased breast cancer risk, or all of that has been retracted, and the FDA has just recently announced that taken off the black box warning of breast cancer, of bioidentical hormones.
Amazing.
Yeah, so we're not limited by those things anymore.
It's great because people are really, you know, afraid of that and had fear of, if I start HRT, which is hormone replacement therapy, that something bad happened to me. And also there is I guess a myth about gaining lots of weight once you start hormonal therapy. Is that so? No.
So people shouldn't be gaining weight with hormone replacement therapy. There's a bit of a fluid retention that might happen, especially with progesterone component of the hormone replacement therapy. I tell people it's like going through puberty again. You are going to see changes. If anything, hormone replacement therapy should shift the weight from the centralized area to the other parts of the body. There is new research showing that when hormone replacement therapy is added onto standard weight loss treatments that we have, it increases the efficacy of the weight loss treatments by 37%. So yes, no, that's not an issue anymore. Those concerns were more when we looked at synthetic hormones.
Nelly, well, it just really came to the point where I'd love to ask you, because it's such a trend now to use that GLP-1 injections for weight loss, and many people are successful, and it's really, I don't want to afraid that word, pandemic.
Yes.
But when we see weight loss, and then we see it differently, and there are some things that does it affect hormonal health overall?
Certainly. So that's a very good question. So I'm a very big advocate of treating excess weight and obesity early, before it gets out of control. The reason that we do that early is we've got internal regulators of weight in our body, which at a cellular level, these turn on at a certain weight and stop us from going down from these weights. So our body is designed to go up with the weight, not to go down.
So it's designed to go up.
Exactly. As a baby, you're designed to go up. We're focused. When you go down, it thinks that you're in a famine or a crisis. So it regulates you to go back up. So we don't want people to get to that level. So the common practice, and this might be a very unpopular opinion, but it's my professional opinion, that the common practice of waiting for people to get to a BMI by itself has a lot of issues, but let's go by BMI at the moment. BMI of 30 and above, and then treat them, is completely wrong.
Just to remind, what's the BMI in body mass index?
Body mass index.
What's the reference, which is normal?
Yeah, so up to 25 is normal, but it is a very variable thing depending on gender, ethnicity, and background as well. Roughly 25. So up to 25 is normal, 25 to 30 is overweight, and 30 and above is obesity. So when you get to that 30, it's already changed into a chronic disease. And if I want to treat a chronic disease, I have to treat it chronically. So when we use GLP-1 analogs or any of those medications that we use for hormonal regulation or weight management, they are going to be long-term treatments and forever treatments. But when intervention comes in earlier, that would avoid us needing long-term medication. So yes, if there is evidence of abnormal weight regain, which generally in women shows itself as centralized weight gain around the stomach area, waist area, and with the new definitions of obesity which was published in the Lancet earlier this year, we don't go by body mass index anymore, and we go by waist to height ratio. So you see a lot of women who are slim, so BMI, let's say 23, which is normal, but when you do a waist to height ratio, their waist to height ratio is 0.7 or 0.8, and that is a very big marker of cardiovascular disease. That's visceral fat, that's bad fat. So now by the new definitions, we actually have the ability to use a very small dose, most of these cases, of proper medication, appropriate if it's appropriate for the person, and as the visceral fat goes away, it's sort of an intra-liver fat as well, which helps the regulations of hormones as well. So like any other medication, when done properly with the person who does know what they're doing, it's great.
Okay, thank you so much for sharing that there is advancement in medicine and we can use it if it's used consciously.
Yes.
You mentioned that there is a connection between ADHD diagnosis and hormonal changes. Could you please share with our audience a bit on that?
Of course. As you know, the criteria for diagnosis of ADHD have changed for women. So a lot of women are being diagnosed later in life because women do not present the same way as men do. So around this diagnosis, we see a lot of exacerbation of the symptoms. And that's around perimenopause and menopause with the hormonal changes that happen. So again, with the function of estrogen receptors on the brain, we see the ADHD brain responding differently to a neurotypical brain. A lot of these women, while they sort of respond fantastically to estrogen, they can be progesterone intolerant, which is very interesting and very hard to manage. Progesterone in our body, usually in a neurotypical body, reduces everything. So like in pregnancy, for example, it gives people constipation, it slows people down, it makes people sleepy. In an ADHD brain, it actually works the other way around and it stimulates everything. So a lot of ADHD patients, when we give them progesterone, which is supposed to, let's say, for example, help them sleep, it makes them more awake and have difficulty sleeping. It makes them more anxious. It makes them have more thought disorders as well. So it's really important what type of progesterone we use, how to manage it, what sort of a delivery we use, and also sometimes I actually have to block ovulation completely and put ADHD patients into complete medicinal menopause and then add back the hormone on top of it. So it's a very complicated and complex field.
I see what you said, that you need so much different types of training in order to provide this kind of treatment and take in consideration so many factors. And were there any cases that women thought that there are symptoms of hormonal changes but they aren't? Yeah,
so I had a lot of people, because there's a big movement around being diagnosed with perimenopause, now we have a lot of women who come in, I think I'm perimenopausal, but there's other things. So I've found thyroid disorders, severe hormonal disorders like Cushing's disease, which is a very rare cortisol-producing tumor, and sometimes it's just poor metabolic health. These patients sort of present with metabolic syndrome, which is a complete inflammation of the body with different sort of organs, like high sugars, excess weight, high blood pressure, high triglycerides, and this all is an inflammatory state. So while they think they are perimenopausal, it's not perimenopause. And it's other hormones, it's not the sexual hormones, it's other hormones, but it presents itself. So yes, there is a very big overlap with other endocrine diseases as well.
I'm glad there are people like you who are trained and have passion and advocating for women's health and explaining to them and normalize some symptoms, and also studying further, advocating for opening clinics like this. And I hope you will succeed eventually.
Yeah, I hope so. But
it's a very lovely dream. And thank you so much for sharing your expertise today, Niloufar. And then we hope to see you again in the studio and share a little bit more in depth. I'm sure we'll get lots of feedback and people would like to find more what to do, how to do, etc. So thank you so much again.
Thank you so much. It's been an amazing talk. And yes, I would love to be back.
Thank you. As we come to the end of today's conversation, one thing becomes very clear. Hormones are far more than biological mechanism. They are connected to how women experience their bodies, their energy, their emotions, and their overall well-being across the lifespan. For many women, hormonal changes can feel confusing or even unsettling. There may be moments where energy shifts, sleep patterns change, mood fluctuate, or the body begins to behave in ways that feel unfamiliar. And often, these experiences are navigated quietly, without enough open conversation or understanding. What today's discussion reminds us is that these changes are not simply personal struggles. They are part of complex physiological processes that every woman experiences in different ways. When we begin to understand the science behind hormones, metabolism, and midlife transitions, we can move away from blame or self-criticism and towards greater awareness, compassion, and informed choices about health. Another important message from today's conversation is the need for continued research and education in women's health. The more we learn, the clearer it becomes that hormonal health is closely connected not only to physical well-being, but also to mental and emotional health. Understanding this connection allows women to approach different stages of life, from early adulthood to menopause and beyond, with more knowledge, more support, and more confidence in caring for their bodies. We're incredibly grateful to our speaker, Niloufar Tokamani, for sharing her expertise and helping us better understand the complex relationship between hormones, metabolism, and women's health. The more we understand the signs of our bodies, the more empowered we become in caring for our well-being. Health is important in both dimensions, physical and psychological. Thank you for joining us on Psychology of Us. Until next time, take care of yourselves and of those around you.